Welcome to the session titled Redefine Simple, Redefine Success, Streamlining My Workflow with the Balloon and Basket PFA Catheter. For this, we have a recorded case presentation from Dr. Philipp Sommer from the Heart and Diabetes Center, North Rhine-Westphalia, Bad Oeynhausen in Germany. We're also joined by Ammar Killu from Rochester and Pasquale Santangeli from Cleveland. Welcome all. I will wait for Philipp to come online and start his case. Thank you, Philipp, for joining us. You are muted.
No, I should be okay.
Okay. Yeah, now we can hear you.
Now it's good. It wasn't me, so I'm off any responsibility. So happy that you can hear me, that you can see me. It's a pleasure to demonstrate to you how I streamlined my workflow with this balloon in basket catheter. Probably everybody knows what we are talking about. And from my side, we could immediately start with the presentation, and here it is. Excellent. And there may be a couple of differences when you see the case, which I recorded on Monday, actually, a couple of days ago. And those differences might also be due to the fact that I'm working in Germany, as Devi was pointing out. And Germany has a couple of, circumstances and requirements that may be different from the US. But I think it's always very helpful and nice to see how things, healthcare systems, etc., do differ, and we can only learn from what other people are doing. So there's a couple of disclosures, and then we can continue with a short intro. You are all familiar with these devices. I probably think that you saw all of them by today, or you will still see them during the day. So there's nothing new about it. And the catheter I'm going to work with is the one in the middle. That is this balloon and basket design. So we have these splines with electrodes on it. It's an over-divider design, as you can see, which is going to be inserted via a 17 French steerable sheath. So the case I'm going to report to you is a 65-year-old, very healthy, very lean guy, a heavy runner, actually, BMI about 22, so very atypical for a German person, but probably also atypical for a US citizen. He just started having AFib about a year ago, normal ejection fraction, relatively small atrium, which might play a role when choosing the right device. So some of the devices might be more or less suitable for really small atria. He has no cardioversions in his history. The CHED-VAR by definition is 2, so he has some arterial hypertension treated with some ramipril, as you see in the bottom line. And per definition, 65 years gives him the second point. So when we assess the risk, how complex the case might be, we all probably agree that a patient with hardly any risk factors besides the arterial hypertension will very likely present with a relatively normal atrium and probably will end up with a PVI approach alone. So you see one of the scores that I from time to time use, the Dr. Flash score, and here only the age and the hypertension do seem to play a role, so the risk would be considered pretty low. The system uses the Insight X platform, so we are providing a map, which, as you're going to see, will be done more or less on the fly, as we say. That means we do not really intensively map prior starting the ablation, but we probably, on the left side, as you're going to see, do a quick map of the left PVs before we start the ablation, and then turn over to the right side. And while doing so, assessing what the posterior wall is doing, what the septum is doing, just to get an idea of which kind of atrium we are dealing with. I stated here that we're using a 13 French agilis. That might be a little bit misleading because we're either talking about inner or outer diameter. So 13 is the inner diameter. The outer diameter is around 17 French. So it's a bigger sheath than the agilis that we're used to, but it, to me, has the same characteristics in terms of the bending and the steerability. We do some voltage mapping, and if there would be low voltage areas, I would have been ready to also deploy some non-PV lesions. So let's go into the case, a balloon and basket. Just to start with a very small introduction, again, we are in Germany. These are our labs. We have 3 of them where we perform our ablations, rather big labs, as I think. Even though we are not regularly using anesthesia, standby, or assistance, but run our sedation by our own. So we have 2 nurses on a regular basis and 2 physicians. So you have Vanessa Schacker next to me, very skilled and blessed operator that we have with us. We have 1 nurse that is with me at the table, and normally 1 nurse non-sterile. For this case, we had the luxury to have a second nurse jumping around. I always do a CT scan up front so that I know which anatomy to expect. And as you may suggest, and as you may anticipate, in these paroxysmal cases, there's no real particular finding, but still from time to time, of course, we find like common ostia here that you might consider a right accessory middle branch, maybe. This is Dr. Schacker doing the puncture, ultrasound guided, of course. And I always place already a short 11 French sheath just to do some dilatation, so to say, in the groin area, which makes it much easier to introduce the Gillis sheath in a second. We're using the 3D mapping system to guide the CS catheter up, and Dr. Schacker's placing the CS catheter non-fluoroscopically. You're going to see that at the end of the day, we're going to have a pretty favorable radiation time, fluid time for this procedure. So our approach to do the transeptal puncture is a very simple one. We use some fluid, we use some contrast and the pressure curve. That's it. We usually do not use intravascular or intracardiac ultrasound or TOE. This is the sheath that needs to be carefully advanced because it's a pretty strong sheath, a pretty stiff sheath, even compared to, for example, the ferrite drive sheath. So I really tend to use some fluid to make sure that the wire goes properly up. I just pull back in fluoroscopy. This is LAO. I had a nice feeling and a nice jump, turning a little bit more posterior, not too posterior. As you're going to see, this is one of the critical steps when doing Volt cases or balloon and basket cases, that you're not getting too posterior. Once I do the puncture, I'm going to inject a little bit of contrast just to make sure that I'm in the right spot, and then I advance the whole thing. Might be very unusual for you guys, and you will say it's impossible to do it without eyes. I can tell you it is possible. And I did a couple of thousands of it, and it works. Then we step over to do the preparation of the balloon. There's some fluid inside the balloon, about 10 ml. So what you have to do at the very beginning is to flush it twice just to get the air out of the system. And then you connect some water, saline, with some 1 to 2 milliliters of contrast dye to make it visible once you insert it. The sheath to me is super reliable, I'm very confident with that sheath. I also perform from time to time angiographies. Here you saw the baseline adjustment, so you have to do some rotation, get in contact with the tissue. And then to facilitate the map, I sometimes deflate the balloon a little bit. So I just took off about 5 ml to facilitate the mapping. And when it comes to ablation, we have to make sure that we know about this, what I just saw in this specimen, that there is lesions which have some gaps in between. So we have to really carefully perform the rotation when doing the first or then the second or maybe third and fourth impulse. So there's one of those energy delivered now in the left inferior pulmonary vein. And it's super helpful to see those e-tags, those tags that are deployed in either white or this bluish color, which kind of reflects the amount of contact that you see in this bullseye view up there. Look at the electrograms. Boom, one shot gone. This is right superior. Again, it's super easy to do the rotation. Once you performed your initial first ablation, now you're going to rotate the whole device. And because there's the balloon inside, there's no way that the splines will kind of unequally distribute. They are always like in perfect distribution. The distance between each of the splines will be very, very similar and very constant. So you can easily rotate the whole thing, those 20-something degrees to kind of get in between your previous lesion. And then here you see that I deploy my second lesion. Usually on the right side, I tend to push down the whole thing with a steerable sheath to the carina region to allow me to do a third impulse on both the superior and the inferior pulmonary vein. So my standard approach nowadays is to do 3 applications per vein, but the last ones usually do emphasize a little bit the carina region, which I think is particularly important on the right side. So you just saw that I was pushing down. Now the critical part, how to get to the right inferior. My approach is deflate the device, the balloon, retract it to the tip of the sheath, deflect the sheath as you see it here. And this is a little bit of force required to deflect because the catheter is quite stiff. Then I'm able to advance the wire and can advance the device and then cross fingers that the wire does not jump out of the right inferior. Once I have inflated the balloon again, I can use the sheath to push the whole thing down and to get in the proper contact. Again, always having an eye on the bull's eye view. The blue ones, they show the optimal contact. And here you, for example, see that I have some suboptimal contact in the more carina region. These are the electrodes 1 and 2. And if I do so, I will deselect some of the splines. So in this case, I deselected electrode 1 and 2 and ablated with the remaining 6. So this, I think, improves a little bit the versatility of that system, that it allows us not to do all or nothing ablations, but really to select the splines we want to work with. And so in this particular case, I deselected the carina ones because I'm obviously pushing downwards quite significantly. Then there's, again, the rotation and the second application. And as you're going to see, the third one again, I will move the sheath a little bit upwards and push to the carina, because as you see here, there's this middle branch on the right side, so which from time to time can also make sense to intubate that middle branch with the wire in a particular way. Looking at the E-tags, you're going to see that they very well correspond with the findings in the post-ablation voltage mapping. But here again, you see that I deselected 2 of the electrodes. In this case, it's the electrodes 2 and 3. Again, this is to see in the middle part of the screen that bull's eye view. The gray ones are the deselected ones. The white ones are the ones that have adequate but not maybe super optimal contact. And then the blue ones are the ones that are above a certain threshold in terms of this impedance measurement tool, which will provide you with some information about the amount of contact that you have. You see already in terms of the electrograms that we, like always with most of the PFA technologies, we got rid of the signals inside the PVs, but probably this is not the decisive factor that should guide our the intensity of our ablation. And then you can see that we can pretty nicely do some quick remapping, so go a little bit inside the pulmonary veins to check that the level of isolation is really as ostial as we like it to have. I do map a little bit the posterior wall, but as we already suspected from the clinical perspective and the clinical characteristics of that patient, this is really a supernormal patient. And here you can nicely see these E-tags, the white and bluish dots, and now you see just the voltage, and this fits very well. Again, don't trap into misjudge a little bit on the importance and the findings of these abolished electrograms. We still have to learn, in my perspective, what really predicts a permanent and a durable lesion. It's probably not the abolishment of electrograms acutely, because we also learned that even though this was a post-ablation map with some other technologies, in a redo a couple of weeks later, it could have looked very, very different, and the lesion obviously was not super durable. I retract the device after having deflated it. We do a quick set suture of the groin. So we usually, as we are a poor country, do not deploy any vessel closure devices on a regular basis. So it's just a set suture that we put above these two exercise punctures in the right groin. And during Dr. Shaka is doing that set suture, I'm just taking a mobile echo machine and do a quick exclusion of pericardial effusion before we remove the sheath. That's what you see here. And then after usually less than an hour, this case is done. The propofol is switched off. You see that the patient just has a butyl tube in his mouth. There's no intubation, endotracheal intubation. There's no mechanical ventilation. There's never been an anesthesiologist in our room, but also this is due to legal requirements that are not present in Germany. So we as cardiologists are allowed, by law, allowed to run the propofol sedation with our specially trained nurses. So overall, we had a pretty favorable fluid time of about 3.5 minutes. And to close that case, this is again the final images of the voltage map. Yeah, so far, we had not had the opportunity to do any remapping because fortunately, none of our patients actually come back so far. We did about 50 cases so far. And yeah, we are pretty happy. And I'm really curious to hear what you think about the German workflow streamlined using this balloon and basket device. Thank you for your attention for the moment. And I'm now, of course, open for your questions.
Thank you, Philipp, for that excellent case. And it's a very efficient workflow for a inbuilt mapping system. I still don't have the guts to do a transeptal without ice, so I'll leave that into your expert hands. I think we're also fortunate that we have ice, right? So I don't see the reason. So, and I think it's good to know that it's possible. But I want to kind of ask you one question. As much as we talk about fluoroscopy and radiation, I see that you do imaging for your PVIs. Is there any particular anatomy that you would not say pick for this case, or is there a reason that you do the CT prior?
Well, I probably should say now that there is a reason why I do the CT prior the ablation. Otherwise, it would not be too logical. But to be honest with you, it's not on a very regular basis that I really deselect the patient from a single shot procedure because of his anatomy. But again, from time to time, there is findings like a common ostia of inferior veins, like a bunch of accessory veins, which could make your life a little bit more difficult, that we from time to time switch on the basis of the findings of pre-procedural imaging. What we also find from time to time, and this is like misconnected pulmonary veins, maybe 5-6 times per year, but we're doing like roughly 1,400 PVIs. I know it's a lot of imaging. It's also a lot of radiation for the patient, even though this is low dose CT, so less than 1 millisievert of radiation dose. And again, to be very selfish, it's a radiation that goes to the patient and none of them goes to us as the physicians, which makes a little bit of difference, like on the table fluoroscopy exposure. And we are very convinced that this can be super helpful and guide us, even though if we're thinking about future indications like concomitant LAA occlusion procedures, stuff like that, we also have not on a such seldom basis findings, incidental findings when doing those CTs in terms of bronchial cancers and stuff. So to me, I don't want to get rid of the imaging, and to me, it's a really important information. Still, I have to admit, I'm not selecting the device only according to this imaging information. In the vast majority, everything is possible, and then we select whatever seems the most adequate system for us.
Ammar, let me ask you a question about this system. And so, we see PFA being widely adopted. I mean, it took us, I've not seen a technology that had so much uptake in such a short amount of time with as much clinical evidence we had. But it has taken, and there's that safety aspect. But we see results in IDE trials, and the results for Volt were presented at APHRS last week and had impeccable efficacy data. Now, we've seen these similar data in ID trials in other PFA technologies, but when we take it to the real world, we're not seeing that as often. Like, for example, we're not seeing that in registry data that we're translating it. Do you feel like systems like this that have integrated solutions might change that? I mean, do you see this is going to take it away from reproducibility of data or streamlining the approach? Because Philipp just showed an elegant way of doing this.
Yeah,
I'm completely. Yeah, go ahead. Sorry.
Sorry, I thought it was for me. Did you say Devi or?
No, it's okay, Ammar. Go ahead. It was for you.
I was going to say, I think with PFA, what we've seen is, as you said, a streamlining of the procedure. So it's just a much more predictable workflow and a much more predictable procedure. So, the time that you're in there is, I think that the spread is a lot less than what it used to be with radio frequency. The safety is significantly improved compared to thermal-based ablation systems. And I think with that, what we've kind of moved to is taking patients that we may not have been as readily willing to ablate with radio frequency because of the various potential issues that we may encounter. And so I think that's been one reason, or is one reason, why we may not see the results in IDE studies, for example, clinical trials, necessarily translated into what we see in the real world outcomes, just because the availability and the willingness to use it in sicker patients is lower than it was before, I would say.
Yeah, Pasquale, I want to, thank you for joining us from Sobrak, by the way. And so just a question on when you see this workflow, and, Volt is not approved in the US yet, and hopefully will be available in the next few months. When people start adopting this, what do you think is going to, what are the things that they should consider? There's at least multiple commercial systems available in the US. And why would somebody want to use the system compared to the current systems that they have available? Or is there specific patients that you see that this would be more valuable?
Yes, it's a great question. Sorry, I have a minimal voice. But first of all, I would like to say that I love the presentation by Philipp. I like the workflow. I wish we could reproduce it with minimal sedation in the US as well. We always tend to do things more in general anesthesia, but it makes just much more sense to do a conscious sedation procedure. It may be better for patient comfort and also for workflow in general. So I think Volt will have an important role for our workflow for all the first-time ablations, regardless of paroxysmal versus persistent. We know that PVI is really pretty much the only strategy that stood the test of time. So, and it seems to me that it's quite simple. It's quite efficient. I don't predict particular issues in terms of the anatomy of the pulmonary veins, particularly when we use ICE, which is our main imaging modality. We don't do CTs beforehand. So I think I like the workflow. I noticed there was minimal movement of the patient with application of energy, which may be an advantage compared to other systems. So I think it's a great system. I think for PVI, for extra PV, of course, they will need to give us another tool. Maybe dual energy TactiFlex will be in the package for these complex cases. But yes, I think it will have an important role. And I think for any first-time ablation, it's very hard to go away from single shot and go back to point by point. So I think single shot procedures are here to stay and will be the way we will do all of this.
Philipp, I see that when you actually did the applications, of course, that patient atrium was a reasonable size. There was enough space in the posterior wall, but there are going to be anatomies where you come up. I'm just going to assume that you have no CT in this patient, so you have no idea what you're coming in for. But if you do sometimes end up with the right and the left superior veins too close to each other. In those cases, as much as this is not designed for a non-PV workflow. What are your thoughts on this catheter being used outside the PV? And there was some data presented last week on that as well.
Yeah, well, I think it's because of this option to select and deselect some of the splines, and maybe I may be a little bit surprising for the technician in the background now, but maybe you can just go back to my presentation, because there was one more slide which actually nicely demonstrates what you can do if you have to do, because this was the case when during the PVI the patient went into an atypical flutter, which I mapped using the balloon and basket device, and then actually had to do this was a perimitral flutter, and I had to do this septal line. And by deselecting most of the electrodes, I was nicely able to even block that line and to terminate the tachycardia. It's not designed for that, as you said, but I also did a couple of times posterior wall isolations. You nicely see which electrodes are in contact with the posterior wall. You select those and you deselect the ones that are just in the blood flow, also to avoid aspects as hemolysis and kidney failure. This is close to zero with this catheter. And you're completely right, the patient movement, so the skeletal muscle recruitment, even if only in like mildly sedated patients, is close to zero. With the first patients we did, I actually asked, was the energy really delivered? Because the patient did not really react the way I know it, like coughing and sometimes moving. And there is differences from technology to technology. Of course, the unipolar ones are much more affecting the patient as the bipolar compared to the bipolar. But this technology is really on the bottom part of the spectrum, I would say. And to finally make a short comment on your question concerning the transfer from IDE results to real world, I would say we all of us can predict how easy and widely applicable a device will be. And that's why LMRs and stuff like that are so important, that we are telling also the companies what might be the pitfalls. And I try to emphasize that with this device, I think once you're on the left side, once you have the balloon deployed, it's a pretty straightforward and easy thing, because most operators will be used to do cryo procedures, and in a way similar to a cryo procedure. But the sheath, to me, is the point where we really have to take care when going to a broader spectrum of operators, because you really have to be careful when having just the wire in the SVC, pushing the sheath up, that it really follows the wire. It's a stiff sheath that goes everywhere, so really pay attention. That would be my advice when it comes to applications. And also to you guys in the US, once you get it, carefully move that sheath up, and then you can do the transeptal, ice-guided, of course. But once you're on the left side, it's a straightforward procedure and super simple. And I think we will have very, very good and durable PVI results, even if less experienced operators will start using this device outside LMRs and IDE files.
Yeah, when I think about this system and think about all the new things that are coming within the platform, there is going to be a sensor-enabled ICE catheter that'll be soon available, hopefully. And I mean, for an operator, they'll be able to create that LA shell very quickly within a matter of a few minutes with auto contouring, and avoid the need for, and with the use of ICE, I would say that many of us would be potentially not using any fluoroscopy for this procedure, especially if you have a contact assessment tool and ICE to assess contact and maneuverability and such. Any final thoughts from any of our panelists? We are pretty short on time, so any brief comments?
Just a quick question.
Philipp, you always amaze me. Beautiful case.
Very nicely shown.
Go
Do you
ahead,
ever
sorry.
dip a little to get deeper into the vein and really try and take out the pulmonary vein musculature in case you get a reconnection osteally, or do you find that's not necessary?
That's the question about the olive, so to say. So the olive is now renamed by the CCB guys in Frankfurt. So they also do the same now with the void as well. Deflate 1-2 milliliters, go deeper, and do some ablations inside. I feel honestly very comfortable with these antral ablations. So I do not create any new vegetables or fruits to do the ablation somewhere inside. I use the deflated balloon to map, because I find it very helpful to delineate the ostium, but the ablation will be always done in my hospital, in our hospital, with a fully inflated balloon and just the one ostial position. So I never ablated with less than 10 milliliters inside.
All right. Well, we have run out of time. Thank you so much, Philipp, again, for that wonderful case. And thank you, Ammar and Pasquale, for your contributions. Next, we're back with Jason Andrade in Vancouver.